Okay, let's unpack this. You know that feeling when you're in medical school, or maybe you're a resident, and you are staring down the barrel of the board exams?
Oh, yeah.
It feels less like studying and more like trying to, I don't know, memorize the entire internet in a week.
The fire hose effect. It is a rite of passage for every physician. You feel like if you even blink, you'll miss a whole chapter.
Exactly. And for otolaryngology ENT, that fire hose is spraying a mix of complex anatomy, microscopic surgery, and systemic pathology right in your face.
Yeah.
It is just overwhelming.
It is, because ENT isn't just ear, nose, and throat. It's
No.
the skull base, it's facial reconstruction, it's the airway. I mean, the stakes are incredibly high.
So today we are capping that fire hose. We're doing a deep dive into ENT board prep high yield review, edited by Doctors Fred Lin and Zara Patel.
Right.
This isn't a textbook reading, this is a tactical strike. We're looking for the pearls, those high yield facts that board examiners just love to test.
Think of this as the audio version of your final review notes. We aren't going to reteach you the basics of how to, use an otoscope.
Right.
We're going to focus on the associations, the warning signs, and the specific data points that can distinguish a passing score from a failing one.
Our mission is to sprint through the major sections: pediatrics, rhinology, general stuff, otology, laryngology, and even some plastics. We want to synthesize this vast field into something you can actually use.
The goal is synthesis, taking all these isolated facts and connecting them so they actually stick.
So let's start at the beginning, literally.
Yeah.
Pediatrics and embryology. Now, I've always found the branchial arches to be a nightmare to memorize. Just feels like random mapping.
It feels random until you look at the function. The editors of this review highlight that if you just nail the first and second arches, you cover a huge chunk of the exam questions.
So help us synthesize that. How do we keep them straight without, a stack of flashcards?
So focus on the action. The first arch is all about M.
M for mandible.
Mandible, yes, but think broader. Muscles of mastication. Chewing. And the nerve that drives chewing is the trigeminal nerve, specifically the third branch, V3.
So first arch, mandible, mastication, trigeminal. Okay, that tracks. The chewing arch.
Exactly. So what about the second?
The second arch is facial expression.
Yes. Smiling, frowning, closing your eyes. That's all the facial nerve, cranial nerve 7.
So first you chew, then you smile.
Precisely. It simplifies the map. If you get a question about a muscle of facial expression, you know it's second arch. If it's about chewing, it's first arch.
Moving from the embryo to the ER, let's talk airway. This is where the text gets really serious. You need to distinguish croup from epiglottitis, like instantly.
Croup is the common one. It's viral, usually parainfluenza. You get that barking seal cough.
Right, but epiglottitis is the killer.
Epiglottitis is the scary one. It's bacterial, classically H. influenza type B. The book really emphasizes the presentation.
The 3Ds.
The 3Ds: dysphagia, drooling, and distress. These kids look toxic. They are sitting forward, just struggling to breathe.
And there's a specific visual clue on the X-ray.
The thumbprint sign on a lateral neck film. The epiglottis is so swollen, it looks like someone literally pressed their thumb onto the X-ray.
That's a classic board image. But there's a specific pearl in this section regarding age that I found really interesting.
This is a classic gotcha question. Say you have a baby, maybe under 6 months old. They have stridor, they have that barking cough.
So you think croup.
You treat them for croup steroids, nebulizers, but they don't get better.
So it mimics croup, but the standard treatment fails. What do you think then?
Exactly. In an infant that young, especially under 6 months, you have to pivot your thinking to a subglottic hemangioma. It's a vascular tumor growing in the airway. It looks like croup clinically, but it's a structural lesion.
That is a crucial distinction.
Yeah.
And speaking of structural issues, the text has a very, very stern warning about masses on the nose.
Yep.
The do not touch rule.
This is arguably the most important safety tip in pediatric ENT. If you see a child with a mass right in the midline of the nose, maybe it looks like a cyst or a dermoid, you never, ever biopsy it in the clinic.
Which seems counterintuitive.
Yeah.
Usually if we see a lump, we want to sample it to see what it is.
Right.
Why is this one off limits?
Because in this specific location, that lump might be an encephalocele. It could be a herniation of brain tissue or dura protruding right through the skull base.
So you stick a needle in it.
You are sticking a needle into the subarachnoid space. You risk a CSF leak or, worse, introducing meningitis.
Wow.
The rule is image first. You need an MRI or CT to prove there is no intracranial connection before you even think about touching it.
That ties into a broader theme I noticed in the rhinology section too. It seems like the nose is a minefield of don't biopsy this scenarios.
It really is. Before we leave PEDS, though, we should mention syndromes. Charge syndrome is a big one.
What's the key association there?
Well, C is for coloboma in the eye, but for the ENT, the critical association is choanal
A blockage in the back of the nose.
Exactly. And don't forget 22q deletion syndromes, which often present with palate issues.
Okay, let's head into the sinuses. Rhinology and allergy.
A fascinating area. Let's start with fungal sinusitis.
The text mentions a histological finding that sounds surprisingly fancy. Charcot-Leyden crystals.
It does sound elegant, doesn't it? Like something you'd find in a chandelier. But in reality, it's a sign of allergic fungal sinusitis.
Okay.
Those crystals are essentially the tombstones of eosinophils.
Eosinophils being the white blood cells associated with allergies.
Right. The eosinophils die and break down, releasing lysophospholipase, which then crystallizes. If you see those crystals under the microscope, you are dealing with an allergic fungal process.
There's also a specific tumor mentioned here that has a unique look on MRI, the inverted papilloma.
The IP, it's benign, but it's aggressive locally. The key word to associate with IP on an MRI is cerebriform.
Cerebriform, meaning it looks like a brain.
Yes. It has a convoluted, folded pattern that resembles the sulci of the brain. If you see that brain-like mass in the nose, you've got to think inverted papilloma. And you need to know the staging system, Krauss staging, T1 to T4, because that's going to dictate the surgical approach.
And earlier we mentioned don't biopsy. We have to talk about the JNA.
The juvenile nasopharyngeal angiofibroma, and this targets a very specific demographic, adolescent males.
The teenage boy with the constant heavy nosebleeds.
Correct. And nasal obstruction. This tumor originates right at the palatine foramen.
And it's super vascular.
It is incredibly vascular. If you biopsy a JNA in the office, it will bleed torrentially. You diagnose it with history and imaging, not with a scalpel.
So for the midline mass in a baby, it's don't touch because it might be brain. For the teenage boy with nosebleeds, it's don't touch because it's a blood bomb.
That is a very effective way to remember it, yes.
Just briefly on allergy, the text mentions neurogenic inflammation. What does that mean in this context?
It just explains that inflammation isn't only about immune cells attacking things. Sensory neurons can actually release neurotransmitters that tell mast cells to degranulate.
So a direct link between nerves and allergies.
It's a direct link, yes.
Let's zoom out a bit. Part 3 of the book covers general, systemic, and pathology topics.
I see.
This feels like the section where internal medicine meets ENT.
Absolutely. The head and neck are often the first alarm bells for systemic disease. A prime example is granulomatosis with polyangiitis, which we used to call Wegener's.
I still hear people say Wegener's all the time.
Old habits die hard. But the pathology is distinct. It's a vasculitis. So if you have a patient with a destroyed nasal septum, that saddle nose deformity, and they also have kidney failure or lung issues, this is your diagnosis.
And on biopsy you're looking for?
Necrotizing granulomas.
Okay. And then there's amyloidosis. I feel like every medical student has this one drilled into them.
It is the classic Pavlovian response in pathology. If I say Congo red stain...
You say apple green birefringence.
Exactly. Under polarized light, the amyloid proteins glow apple green. It's the gold standard.
SR-coded?
Non-caseating granulomas. Clinically, you're looking for hilar lymphadenopathy on a chest x-ray.
What about fluids? The book has a 1.2.3 rule for electrolytes. I love simple math. How does that work?
It's for maintenance fluids. To keep the electrolyte balance steady, you need 1 millieq per kilogram of potassium, 2 of sodium, and 3 of chloride.
1K, 2Na, 3Cl. Easy.
It's a great mental shortcut for writing orders. And while we are on the topic of keeping patients alive, the text flags albumin levels.
As a nutrition marker?
Yes, but specifically as a crystal ball for surgical outcomes. If a patient's albumin is below 3.5 milli-GDL, the risk of complications, wounds not healing, fistulas, it just skyrocket.
It's a huge red flag.
A huge red flag before you take someone to the OR for a big head and neck resection.
Speaking of resections, let's talk cancer, head and neck pathology. The thyroid is a huge topic, but for the boards, there is one visual that always comes up for papillary thyroid carcinoma.
The orphan Annie eye nuclei.
Which is a reference that gets more dated every year.
It really does. But the concept is that the nuclei look empty or clear, kind of like the cartoon character's eyes.
Yeah.
You also see psammoma bodies, which are these microscopic calcifications.
Now, for salivary glands, the text focuses on adenoid cystic carcinoma. This is the one that's notorious for nerve tracking, isn't it?
Paraneural invasion, yes, it just crawls along the nerves. But the pearl here is about prognosis based on the shape of the cells, the histology.
So which shape do we want to see and which do we fear?
You want to see tubular, that has the best prognosis. You do not want to see solid. The solid variant is the most aggressive.
So solid is solid trouble.
That works perfectly.
Let's move over to part 4. Otology and neurotology. We deal with hearing loss every day, but the boards love the basic metrics, the pure tone average or PTA.
It's the anchor point. PTA is just the average of hearing thresholds at 500, 1000, and 2000 hertz.
And why those specific frequencies?
Because that's where human speech lives.
Simple enough. And what about OAEs? Otoacoustic emissions. I always think of this as the ear talking back.
That is literally what it is. The outer hair cells in the cochlea vibrate, and they actually produce a tiny sound. We can record that.
And the utility?
2 main things. First, newborn screening, because the baby doesn't have to raise a hand. Second, catching malingerers.
People faking deafness.
Right. You can't fake an OAE. If the machine picks up the emission, the cochlea is working, regardless of what the patient tells you they can or can't hear.
Now, the facial nerve. This is high anxiety territory. If a patient comes in with facial paralysis, say after a trauma, we want to test the nerve. The text talks about ENT electroneuronography. But it says, wait.
This is counterintuitive again. You want to know if the nerve is cut immediately?
Of course.
But if you test it on day 1, it might still conduct electricity because the nerve fibers distal to the cut haven't died yet.
They haven't undergone Wallerian degeneration.
Exactly. And that degeneration takes about 48 to 72 hours. So if you test too early, you get a false negative. You think the nerve is intact, but it's actually severed.
So you have to wait.
You have to wait those 2 to 3 days for the data to be real.
That's a critical timing detail. And clinically, how do we distinguish Bell's palsy from Ramsay-Hunt syndrome?
Pain and blisters. Bell's palsy is typically a painless or maybe mildly uncomfortable weakness. Ramsay-Hunt is herpes zoster oticus. You see painful vesicles in the ear canal or on the ear, and the facial paralysis is often much worse.
Let's talk about dizziness, vertigo. Benign paroxysmal positional vertigo, BPPV, is the most common cause.
Right, loose crystals. And the text gets deep into the physics here. It talks about ampulla-pedal flow.
Which sounds like a spell from Harry Potter.
It does. It means fluid flow toward the ampulla of the semicircular canal. In the lateral canal, that flow is excitatory. It stimulates the nerve. Knowing that physics helps you interpret the eye movements, the nystagmus, to figure out exactly where the crystals are.
And if the ear exam is totally normal, but the patient is still dizzy?
Then you look at the brain. Multiple sclerosis is the great mimic here. On the boards, if you see a young patient with vertigo and white matter plaques on MRI or oligoclonal bands in the spinal fluid.
The answer is MS.
The answer is MS.
Let's head down to the larynx, the voice. A common clinical question. Is it a cyst or polyp? They both just look like bumps on the vocal cord.
To the naked eye, yes.
Yeah?
But the boards want you to know the stroboscopy finding. You need to look at the mucosal wave, the ripple of the tissue as it vibrates.
And the differences.
A cyst is a fluid-filled sac deep inside the tissue, so it anchors the mucosa and the wave stops. No wave.
Okay.
A polyp is usually more superficial, so the wave can still ripple over it in most cases.
So no wave equals cyst. Wave present probably means polyp.
In about 80% of cases, yes.
We should also touch on the nerves here. The superior laryngeal nerve.
The SLN. It's split into 2. The internal branch is sensory. It feels the top of the larynx. The external branch is motor, but it only innervates one muscle, the cricothyroid.
The high note muscle.
Precisely. It stretches the vocal folds to change pitch.
Let's wrap up with trauma and plastics. The Lefort fractures. These are the classic mid-face breaks.
And visualizing these is key. Don't just memorize numbers.
Okay, walk us through the visualization.
Lefort-Thirst is a low horizontal fracture above the teeth. It separates the palate from the rest of the face.
So you have a floating palate.
Exactly, Lefort-Third.
That's the pyramid.
Think of a pyramid. The fracture goes up around the nose. So now the maxilla, the upper jaw in nose, is loose. A floating maxilla.
And the Lefort-Third is the worst.
This is craniofacial disjunction. The fracture line goes through the eye sockets and the cheekbones. The entire face separates from the skull base.
So, floating palate, floating maxilla, floating face.
Exactly. It's a ladder of severity.
And what about the eye socket itself, orbital fractures?
The orbital floor isn't flat. The text describes it as having a lazy S configuration, Knowing that contour is essential when you are putting in a plate to reconstruct it.
If you make it flat.
If you make it flat, the eye won't sit right. It'll sink.
Finally, when we are putting these faces back together or closing defects after cancer surgery, we use flaps. The text mentions RSTLs, resting skin tension lines.
This is crucial for scarring. Skin has a natural grain determined by the underlying muscles. If you make an incision parallel to these lines, the skin edges naturally want to stay together.
And the scar heals beautifully.
Right, but if you cut across them,
You get a wide, ugly scar.
the tension pulls the wound edges apart. As a surgeon, you always want to hide your work inside those natural lines. We also need to think about the aging face.
Gravity takes its toll.
It does. The nasolabial angle, the angle between the nose and the lip decreases. The tip of the nose droops, and the brow fat pad slides down, which can make the eyelids look heavy.
So you have to address the brow.
Right, not just the eyelid skin to get a natural result.
Okay, we have covered a massive amount of ground, from embryonic arches to facelift incisions. Now, I want to put you and our listener to the test.
Let's do a review exercise.
Yes. Picture this. You are the resident on call. It's 2 a.m. A terrified parent brings in a 4-year-old. The child has a firm, grape-sized mass right in the middle of the bridge of the nose. The parents are begging you to just cut it off because it's getting bigger.
High pressure scenario.
What is your absolute first step? And what is the one thing you must never do?
My absolute first step is to order imaging, a CT, or an MRI. And the one thing I must never do is biopsy or excise that mass in the ER.
Why?
Because of the do not touch rule, that mass could be a nasal dermoid with a sinus tract extending through the skull base. If I cut into it, I could rupture that tract, cause a CSF leak, and give that child meningitis.
You need to know the anatomy.
Before you touch the pathology.
Perfect. That scenario combines embryology, imaging, and patient safety all in one package.
It's the ultimate board question.
So as we finish this deep dive, what's the big takeaway? We've talked about crystals and nerves and fractures.
You know, when you zoom out, you realize that ENT isn't just about fixing broken parts. We are dealing with the senses.
Hearing, smell, taste, speech.
Exactly. Breathing and eating are about survival. But speaking, hearing, and facial expression, that's about connection. That's how we interact with the world.
That's a powerful way to frame it.
The ENT specialist is the guardian of that connection. We preserve the structures that make us human. Whether it's saving a facial nerve so a patient can smile at their daughter, or restoring hearing so they can listen to music again.
It's giving people their lives back.
It is. It's high stakes, but that's the reward.
That is the perfect note to end on.
Yeah.
You aren't just memorizing branchial arches. You are learning the architecture of human connection.
Precisely.
To everyone listening, go back to the text, review those pearl sections, and trust your preparation. You've got this.
Keep studying and stay curious.
We'll see you on the next deep dive.